then she has, anyway, we're going to make the most of having her here, and we're really excited about that. Dr. Cluver is a university lecturer at Oxford, England, in evidence-based social intervention. She's also a very busy researcher, particularly focusing on the impacts on children of AIDS orphanhood and parental AIDS illness, and she leads the Center for AIDS Interdisciplinary Research at Oxford. But what grounds Dr. Cluver's work is that she is a social worker at heart and in practice, having been a social worker in South Africa and in the UK. Dr. Cluver has been gracious enough to share her expertise as part of a scientific advisor to UNICEF, to WHO, to the South African National Action Committee for Children Affected by AIDS, and most important to us, to also supporting PEPFAR programs and helping us, and Peace Corps programs, helping make sure that our training packages, particularly for volunteers working with orphans and vulnerable children, are evidence-based, and we just really appreciate her generosity in helping us with those projects. And now we're going to continue to benefit from her research and insights this morning. She's going to be presenting on 3 different kind of subtopics of this whole general topic of using evidence-based strategies to enable youth to thrive. And the first one is going to be on AIDS in the context of families and the risk and protective family factors on children. Then talking about the latest research on helping HIV-positive teenagers take and stay on antiretroviral drugs. And then lastly, helping families support children and teenagers. We're going to take them in blocks and just have a few minutes for clarifying questions after each section. So keep those in mind. And then at the very end, we'll open it up for a broader discussion. Thank you very much. Please join me in welcoming Dr. Lucie Cluver.
Thank you. It's lovely to be here. What Bev didn't say is that when I was a social worker, I spent about 60% of my time completely lost driving around townships in South Africa, and the other 40% of my time forging documents so I could get child support grants for children. Not much has changed, actually. So let me get the clicky thing working. Oh, I'm not touching it now. Brilliant. Well, what's going to happen inevitably is that I'm going to get carried away and forget to stop. So Bev's going to jump up and pause me. If I'm not making sense, or if I'm talking too fast, or if my strange South African / English accent starts to be incomprehensible, just wave your arms in the air. You can wave your arms in the air anywhere. So. This is actually our teen advisory group, some of the kids in our teen advisory group, and they are horrified when I show this picture because they say it was last year's haircuts. So I'm going to talk to you today about some research that was really set up to inform policy and programming. And many of the people in this room are actually people who've contributed, and particularly Bev, to the development and planning of what's gone into these studies. And you can see the set of partners who we've worked with. About 95% of the time working with all of these agencies is wonderful and brilliant, and 5% of the time it's a complete nightmare. But perhaps we'll leave that for later. And actually, one thing I discovered very importantly is when you're presenting to the South African government department, you need to put that department bigger than the other ones and in the middle. So we're going to talk really, can we make the little toggle thing at the bottom vanish, do you think? No, we can't. All right. Yes, we can. So I'm going to talk really about 4 studies, and I'll touch base through each one of them. The first one was the first longitudinal study of AIDS orphanhood in the developing world. And what we did essentially was we interviewed 1,050 children who were AIDS orphaned, other orphaned, and non-orphaned in the Western Cape of South Africa. And 4 years later, we followed them up. And we got about 75% of them 4 years later. The second study is the world's largest study of children in AIDS-affected families. And we interviewed 6,000 children in 3 provinces of South Africa. And I'll explain a bit about that, 2,500 of their caregivers. The third study is the world's first community-based study of HIV-positive adolescents, and we're still in the middle of that, but we've got some early results. And the last study is an initiative that USAID-PEPFAR has been an increasing part of, which is developing and testing free child abuse prevention programs for the developing world, particularly for AIDS-affected families, but they're available for anyone. So first, we're going to talk a bit about some of the risk and protective factors that come along for children with family AIDS. Oh, and I should actually say that's again, we have all of our projects work with our teen advisory group of AIDS-affected children. They started off as about 12 kids. There's now about 20 of them, and quite a lot of them have kids of their own now. So we take them camping every weekend, every year. Every weekend might kill me. And last year we managed to not have enough bedrooms, so I slept in the back of a pickup truck with 2 of my PhD students who will never respect me again. So this first set of findings mainly come from this study. And essentially what we did was we originally picked 3 provinces in South Africa, and then our president got thrown out and replaced by another president who didn't like the first president, and they changed around all of our provinces at the last minute. But anyway, in 3 provinces in South Africa that were not randomly selected, we randomly selected 1 health district in a rural area and 1 in an urban area with over 30% HIV prevalence. And then in each of those areas, we randomly selected census enumeration areas or tribal authority areas. And then we interviewed in those every single household that had a teenager aged between 10 and 18. A year later, we went back and interviewed them all again. And what was really amazing and lucky about this study was that at baseline, we had an under 2% refusal rate, and at follow-up, we only had a 3% loss. So it's an incredibly representative study of what's going on in urban and rural high prevalence areas in South Africa. And if you've got any questions about methods, I'm happy to answer them. And essentially one of the things that we found increasingly important, and you guys all know this from programming, is that if you walk up to a teenager with a clipboard and a disapproving expression, you're going to get a whole set of answers that aren't what you really need to know. So all of our work tries to make things fun and engaging and cool, and we're hoping that Beyonce is never going to sue us for slapping her photo over 8,000 questionnaires all over South Africa. We also had certificates that said that the kids were all assistant researchers at Oxford University, and I was told after we'd given out 7,000 of them that it was completely contravening Oxford copyright. Anyway, so what do we find? Well, we found some very clear evidence that living in a family affected by AIDS affects a range of outcomes for children. So here we can see food insecurity, and on the left is children who are either living with a healthy caregiver or orphaned by something else. Now this could have been homicide, suicide, diabetes, heart disease, cancer, or who lived with a caregiver who was sick with something else. And we can see that all of those hover around the 15% mark, report that they haven't had enough to eat for 2 or more days in the last week. If you look to the right-hand side, you can see children in AIDS-affected families. AIDS orphan, that immediately doubles to 23%. Those with AIDS-sick caregivers, it trebles to 32%. And the most affected seem to be something called dual-affected. That's children who've lost 1 or more parents to HIV/AIDS and are now living with an AIDS-affected caregiver. Sometimes it's the surviving parent, and sometimes they're living with an aunt or an uncle or grandparent who's HIV-affected themselves. We also see very similar patterns for stigma, and this is kids reporting that people won't touch them, other kids won't play with them, people treat them differently, particularly gossip is something that's very strongly experienced. And you'll see again that rates double and then treble for AIDS-affected children. If we look at psychological distress, this is just looking at anxiety and depression, but we see the same pattern for post-traumatic stress disorder. You can see that rates double and then treble in terms of clinical level disorders for children who are affected by AIDS. It's interesting, we see particularly high levels of anxiety amongst children who are living with an AIDS-sick caregiver. And when we did qualitative work after that, we asked them why. The main explanation was that they were scared to go to school, they were scared to go out because they were worried that the person at home was going to die while they were away. We also see, and this was something that surprised us. In all the research evidence on child bereavement, you see that children are very, very distressed for about 2 years after a parental bereavement. And then they tend to level out. And after about 2 to 3 to 4 years, bereaved children will do generally as well as other children. And you can see that actually with the dark blue line of other orphan children. But if we look at the AIDS orphan children, you can see that their distress levels and their levels of mental health distress are actually going up over time. And this really told us that we need to start thinking very hard, not just about the younger children who are AIDS affected, but also as they grow up, increasing through adolescence. We're also seeing direct medical impacts of family HIV/AIDS. And this seems to be a particular problem when a caregiver has tuberculosis. And often the child will be the person who looks after that person, who rubs their chest when it's feeling congested, and who gets coughed on. Especially, and we all know this, when you're living in small homes that don't necessarily have very good ventilation or heating. And what we see is that a child who's living in a healthy family, who's got enough to eat, has about a 1.5% chance of having pulmonary tuberculosis. That's about normal for the population of children in South Africa. If they live in a family with HIV/AIDS in the family, they're providing care for that person who's sick. If the house is overcrowded and they're hungry, they've got an 18% chance of having pulmonary tuberculosis. Perhaps even more worrying, of those children who had all the symptoms of pulmonary TB, only 25% of them had ever had a tuberculosis test. So we're seeing that family AIDS is leading on to severe medical outcomes, but also perhaps that health services aren't yet aware of the connections that need to be made in terms of that. We have talked to the Minister of Health about that in South Africa, and I think things are improving there. Perhaps most worryingly, we're seeing very high rates of child abuse in AIDS-affected families. We see around doubled or trebled rates of physical, emotional, sexual abuse and domestic violence. When we looked at this using structural modelling to try and understand why, it seems that the main two drivers for parents of this increased levels of child abuse is increased poverty and increased mental health distress. The sexual abuse seems to be happening outside the home and not inside the home, and we're still trying to really understand what the dynamics of that are. But it may also be because there just isn't as much opportunity to monitor kids. It's not as easy to monitor kids when you're sick and stressed and things are really difficult in your family. We also see cumulative effects, and that's when one thing can go wrong in your life, but when multiple things are going wrong at the same time for kids, we see a kind of additive effect that is more than just the sum of its parts. So we can see this very clearly here with adolescent girls and their risk of having transactional sex. Transactional sex is generally sex in exchange for food, money, shelter, school fees or transport. And what we see on the left is that a girl living in a healthy family who isn't abused and has enough to eat has a just under 1% chance of having transactional sex. If you look to the right, you can see that a girl who lives with an AIDS-sick parent, is abused and hungry, has a 57% chance of transactional sex. Now, when we looked at this was quite a shock to us, because we'd really been thinking about sexual risk behaviour as a behavioural choice. We'd been thinking about looking at behaviour change programs and educational programs. And really, when we got these results for the first time, we looked at them and we thought, maybe we're thinking about the wrong things here. If living in an AIDS-sick family, being abused and being hungry, all of the things which are not affected by behavioural choice are increasing their risk 57 times, we need to start thinking about structural interventions, perhaps instead of, but certainly as well as behavioural ones. And we'll talk about that a bit more later. We then tried to understand a bit more about how these things might be linking together. And this is called structural equation modelling, which is a sort of fancy statistical way of throwing all of these factors up together and running them as a joint model to see how they link with each other. And what we can see here is that family AIDS leads directly into increased rates of stigma and poverty. It leads directly and indirectly from those into increased rates of abuse. which leads to increased psychological distress amongst teenagers, which leads then into a circular problem of psychological distress, education risk, particularly school dropout, and HIV risk behaviour. Now, this is in some ways a really sad story. This is the story of things going wrong for kids. But in some ways, it also gives us some opportunities to think about where we could interrupt these pathways. Some of these pathways we're not good yet at interrupting. We don't actually know what to do to reduce stigma. We're working on what to do to reduce abuse. But we do have interventions that have been proven to reduce poverty, to reduce psychological distress, to reduce school dropout. And if we can interrupt those pathways of risk, we might end up with kids who don't have this whole cycle disadvantage. Around this time, there was a set, we were discovering all these structural drivers for risk for AIDS-affected young girls, particularly, but also boys. And the World Bank was thinking rather differently about how we could reduce HIV risk behaviour. And this is a trial that they did in Tanzania. They've also done very similar ones in Lesotho and Swaziland of cash incentives. And essentially what they do in these trials is it's a randomised control trial. Hands up if you're familiar with randomised control trials. So, you guys know all this stuff. Don't know anything. So it's a randomised control trial in which the cash incentive, you had 4 monthly STI testing. If you came out clean, so you had no sexually transmitted infections, you got either $20 or $10 or nothing. And this went on every 4 months. If you did have a sexually transmitted infection, you got no money at all. So the idea was that the teenagers were making a decision to have fun and have sex, but the alternative reward of either $10 or $20 would incentivize them not to have risky sex. So what this trial found was that for $20, HIV risk reduced. For $10, it didn't. We're not quite sure, what this means. The World Bank continued to run another trial of cash incentives very similarly in Lesotho, but because this was seen to be too expensive, instead of doing this for everyone, what you got instead was a lottery ticket. If you were STI clear, you got a lottery ticket, and then every month there was a lottery in your village, and you could win up to 1,000 rand, which is $100 or so. So a whole set of questions came up around this. One of them was about how are we thinking about money and HIV risk for adolescents? And others were a set of moral questions around is it right to be approaching adolescents in this way and testing them 4 monthly and premising it in this way? And there was also some questions around what happened when girls got raped and acquired an STI, or boys got raped and acquired an STI, absolutely not through a behavioural risk, but were then doubly punished by having their cash removed. And often this cash was being used for subsistence, it wasn't an additional piece of money. There were also questions around the administrative complexity. And anyone who's worked in Sub-Saharan Africa can appreciate that there is a high level of administrative complexity in terms of getting 4 monthly STI testing, which we've never managed in any country I know, in Sub-Saharan Africa, and then linking it to a cash system, and what the potential is for corruption and challenges there. However, the trials are showing some effect. And so we started to ask, is it the incentive, or is it just the extra cash that's helping them? And at this point, UNICEF and PEPFAR came to me and said, could we look at South Africa, where there is a child cash transfer, it's the child support grant, but it's unconditionally provided by the state for poor families. And they said, could you just have a look and see whether it's having the same effect? Well, it took us 18 months to work out how to do it, but with something tricky called propensity score matching, we did. And the results were very clear. For girls receiving a child support grant, being in a family that receives a child support grant, it's about $20 a month for the whole family, halves the incidence rates of transactional sex, and reduces by 2/3 the incidence rates of age-disparate sex. That's sex with a partner more than 5 years older than you. It doesn't seem to affect a range of other HIV risk behaviours for girls. It didn't affect casual sex, it didn't affect sex where you were drunk or on drugs, It didn't affect multiple partners. It seemed to not affect the kind of stupid things that teenagers do. But it did seem to be allowing adolescent girls to make decisions about who their sexual partner was, and that they chose sexual partners who were younger and less risky. They didn't need to have a sugar daddy. I made the mistake of saying that at a meeting, and the next morning in The Sun, which is our big tabloid newspaper in South Africa, it said, Oxford University says no to sugar daddies. But what was also interesting was that the cash transfer did nothing for boys. So what we seemed to be getting was a partial effect, but a really important effect. We know that transactional sex and age-disparate sex in the countries that we work in is a huge driver of infection rates.
Did you say you didn't do anything for boys?
Didn't do anything, no difference for boys at
Well,
all.
was there transactional sex in boys from the other?
It's a good question. There wasn't much. Yeah, there wasn't much. And we don't know whether that's because there just isn't much of a market for it. It really, in South Africa, the dynamic of transactional sex is older men and younger girls. You don't tend to see it the other way around. So in a country where there was more in the other direction, it would be very interesting to look at that. But it just did nothing for boys at all, the cash alone. Just a couple of weeks later, a paper came out from Kenya looking at their Kenya OBC cash transfer. And interestingly, they found almost identical results that we had done in South Africa. But we then got challenged, and I don't know if people know David Wolfson at the World Bank, who looked at these results and said, look, this is all very well, but you're finding a partial effect. You're only finding it on a couple of outcomes, and you're only finding it for girls. You know, is this really good enough? And we went back to think about child development. And if you look at things like youth offending, we know that you need multiple inputs in order to get a positive outcome. And so we thought, well, it's not just necessarily about cash. What about psychosocial care? Would that make a difference for these teenagers? So we looked at whether cash and care together might reduce incidence rates of these HIV risk behaviours. And here, if you look to the left, you can see the kind of more cash-focused interventions, and on the right is the more care-focused interventions. We actually measured about 30 interventions, but many of them, so few kids got that we couldn't include them. Out of our sample, our longitudinal sample, nearly 4,000 adolescents, we had 3 who were receiving regular home-based care. We had 6 who were receiving regular food parcels or soup kitchens. So some of them were so low that we really couldn't analyse them. Well, the results surprised us and were really interesting. For girls, we found that cash did have a reduction effect, but when you added care, that reduction effect increased even more. So you had halved rates of incidence of all HIV risk behaviours, not just transactional and age-disparate sex. For boys, again, we found that cash alone had no effect, but cash plus care had a 50% rate incidence reduction in all HIV risk behaviours. It seems like our boys, who swaggered around looking kind of cool, were the real ones who really, in a sense, most need this psychosocial support. At the moment, we're still trying to understand why this is, and what I'm showing you now is analysis in progress, so any mistakes in it, apologise to me, we're still working on this. But we're trying to understand why is it that teenagers are having these risks, and how might cash and care interrupt them? So if you look on the left, we looked at predictors of new HIV risk behaviour in 2012. We looked at what was going on in their lives the year before. And we see that the strongest predictors for teenagers are hunger, community violence, parental HIV/AIDS, and living in an informal settlement. But those things don't go directly into HIV risk. What happens instead is that we call it structural deprivation, the nasty environment that you're living in leads on to a set of bad things happening in your family and for you as a teenager, particularly child abuse, drug and alcohol use, and school dropouts, and for boys more than girls, psychological distress, which those are what lead on to the HIV risk behaviour. Now, when we add in cash and care, this is something called a multiple moderated mediation model, which I make people say as often as possible. But what we can see is that cash and care are both directly interrupting these pathways. They're reducing the rates of psychosocial problems, and by doing that, reducing the rates of HIV risk behavior. But we also see something interesting. There's one diagonal arrow, which is a double arrow. You can see it hits between structural deprivation and psychosocial problems. And this is for girls. What that tells us is that social protection or economic support works even better for those who are most structurally deprived, those living in the worst environments. What's really exciting to us about this is that we know most interventions work better for those who are better off. Many of our interventions, we worry that we're missing the most vulnerable, whereas these seem to be working even better. Watch this space, we're still trying to get these right. I was rerunning them on the plane last night. For boys, it's a very similar pattern actually. We were surprised by that. One of the things we've also realized is that our cash and care categories are actually too few. What seems to be really important as well is school-based interventions, and we've had to realize that our cash and care has had to become cash, care, and classroom. We've also been trying to understand what specific combinations might work, and this is because I presented this stuff to a bunch of policymakers in Sub-Saharan Africa, and they were like, oh, all very nice, your theoretical models, but we want to know if we should be doing school feeding and parenting programs, or whether we should be introducing, cash grants and teacher support programs. They were not impressed by this. So what we worked on instead was this, which tries to understand which combinations of programs will work for different types of HIV risk for boys and for girls. So I'll just explain this. We've divided the HIV risks into what we call careless sex and commodity sex. Careless sex is casual sex, multiple partners, sex drunk or on drugs. Commodity sex is transactional and age-disparate sex. We originally called them stupid sex and starving sex, but we decided that it was just so politically incorrect, and then we started hearing people saying it and realised it's too late. And what we did on the bottom was we looked at all the different potential combinations, and these were the ones that survived multiple regression analyses. And what you can see is that the ones in dark grey are the ones that survived. So for males reducing careless sex, it was free school and free school books and good parental monitoring. For females with commodity sex, it's child grants and free school and books. What's exciting beyond this is that it's not just that these things survive independently, but that just like the bad things accumulated, remember when we looked at the red graph for transactional sex, it seems like the good things are accumulating as well. So we see additive effects of adding two or more interventions together. So I'm really sorry about small writing, I couldn't get this any bigger. But if we look at boys and careless sex, we can see that with no interventions at all, they've got about 20% incidence rates. That means in 1 year, 20% of them will start having these HIV risk behaviours. We can see that if we add any of free school, parental monitoring, or teacher support, that goes down to around 17 to 15%. But if we add two of those together, it goes down to around 7%. And if we add those three interventions together, the incidence rates go down to under 5%. For girls, we see very similar, that there's less things combining, but the effects are just as strong. With no interventions, it's at 15%, and with both school feeding and good parental monitoring, it goes down to 7%. For girls' economic sex, it seems to be parental monitoring, child grants, and free school, going down from 11% with none of them to 1.5% with all three of them. And for girls with pregnancy, which we just added in, particularly because it was interesting us about school dropout and the linkages with that, we see rates of pregnancy in the past year going down from 6% with none of these interventions, but with good parental monitoring, free school and school feeding going down to under 1%. Oh, this is where I have to stop.
That's right. Okay, any clarifying questions? We'll just take a few minutes to ask a few questions.
Back on the graph where you showed the girls and boys, talked about no effect, but the graphs looked quite similar. I'm just wondering if the sample sizes must have been just very different or something.
Oh yes, it's because, It's because that's model percentage probabilities and they don't show quite as much, sorry. It's a stats thing.
Yep.
But you're right, it looks really good, but there was no effect, no statistical effect of cash alone. But when you added cash and care for boys, you did get an effect. That's what really excited us there. And I think that's been really the psychosocial care stuff is something Peace Corps has been talking about for 30 years, 50 years. And it's something that's been really under-recognized, and particularly in the HIV world, where it was all about behavioral programming and then thinking about cash incentives. The enormous impact of care suggests that we're getting something wrong here. There's something else going on for these kids.
And we'll talk more about what CARE means and what that's involved later on in the program. Any other questions?
So much for your presentation. I have two questions. One of them is how do you measure the psychosocial distress? And the second is sustainability, of course, which is what you're going to cash grant.
Yeah, great question. So the psychosocial distress we measured using standardized questionnaires, standardized psychometric questionnaires for depression, anxiety, post-traumatic stress disorder, and suicidality. We use the Child Depression Inventory, we use the Revised Children's Manifest Anxiety Scale, the Children's PTSD Checklist, and the mini psychiatric interview for kids. A couple of them were illegally used, you're meant to pay for them. So I'm very happy to share my copies in Zulu if it's any good to anyone. I don't believe in paying for these things. The question about sustainability is a really interesting one. And UNICEF and the UN have been working really hard on this, and now PEPFAR is thinking about this a lot in the Dreams Initiative. What seems to work with cash grants is that it's really important for the kids that they're sustained. The one-off doesn't seem to make any difference for them at all. And even having a grant that lasts for a few years and then stops doesn't seem to have much of a long-term effect. It seems that the grant works when you get it and when you get it regularly. What seems to work for that is partnering with governments to provide a grant system. And apparently once a government's introduced a child grant system, they can never take it away again, as long as it's a democratic country, because they will always get voted out of office. So various UN agencies are working to get governments to start them. I think not mentioning to them that once they start, they can never stop. But they are sustainable in terms of economics. There's been some great research done on what proportion of GDP they are. I'm happy to share it with you by much cleverer people than me.
And dependency on that?
So it's an interesting question, and people often ask about dependency, and people will often say about teenage girls, will they not just get pregnant to get the child grant? What's interesting about that is that it's a sort of universally held myth. There is no evidence whatsoever that a few people might do it, but there's no evidence on national levels that you get increased rates of teenage pregnancy where you get a child grant. And in fact, in some of the places where you get a child grant, and generally you see decreased rates of teenage pregnancy, perhaps because girls are having sexual behaviour as teenagers. It's really interesting though, but we worry about it a lot. No evidence at all. Yeah.
Correlation, you had a high correlation for girls for feeding in schools, and better lower risk behaviors, but not for boys. Do you know why that would be?
No idea. Sometimes with these huge statistical data sets, the people who work on the ground with teenagers understand this stuff much better. What we do seem to know, though, from other research, is that for girls, staying in school seems to be particularly important in reducing their HIV risk. People guess it might be because they're just not hanging around on the streets. It might be because then if you stay in school, you're more likely to be dating schoolboys and not older men. And some people think that's probably the dynamic of why it's reducing their HIV risk. But there's very strong evidence that staying in school is protective for girls. And I think that's something that Peace Corps is really thinking about in terms of what are our strategies for keeping girls in school. And that alone might be enough to protect them.
And yet what you found for boys was that free school tuition and books was really important. So is it also, is it just as important for boys?
This was boys, wasn't it, with careless sex?
There's a better, well, when you had the squares, that's that.
These ones, yeah. So for boys, absolutely. So we see free school, parental monitoring was particularly important for boys. And that's things like parents knowing who your friends are. It doesn't need to be a biological parent, your caregiver. Knowing where you are when you go out. You don't go out without a set time to be home. It's really kind of keeping tabs on them. The reason why we added in school books is because in South Africa you get supposedly free schools that aren't really free. Do I need to move on?
I think, thank you very much. Write down your question.
Yep.
Sorry,
No problem.
but write down your question, and at the end we'll keep hanging around answering questions. Thank you.
And I talk too much, so I need to be stopped
No,
to get to time. So this little girl up here is called Bonsile, and she's the reason we really started this next study. We found her when we were doing the study I just described to you, and she collapsed on the side of the road with her school books on her back. And it transpired that she was HIV positive, but had never been tested. Got her to the clinic, started her on antiretrovirals. She had a very complex family background. And this little girl, she's actually 15 in that picture, found it intensely difficult to take her antiretrovirals. And we worked with her far more emotionally involved than we probably ever should have done, but for a couple of years, and she passed away last year. But in the meantime, we realized that this wasn't just Bonsile. This was a national problem. At the moment, South Africa has 1.2 million HIV positive adolescents. In Sub-Saharan Africa, the numbers are much bigger. And we really don't know how to deal with them in terms of helping them survive and keep continuing to take their antiretroviral medication. The data on medication adherence amongst adolescents all over the world is amazingly low. And I came out to New York to work with Claude Mellons and her team at the New York State Psychiatric Hospital. They do absolutely superb research there. And they're finding incredibly low rates of adherence with these kids who have like counselors and social workers and psychiatrists and psychologists, and all the team meet regularly to discuss I mean, it's fantastic care, and yet they have very low rates. In Sub-Saharan Africa, there's a few studies, and the studies show rates of between 10 and 25% adherence to ART. That's in normal state clinics. If they go to one of the kind of super special Baylor clinics, it seems to be a lot higher. So we decided to start a study that would really try and understand what is stopping teens from taking their ART and what might help them to take it. And I still don't know yet whether this was genius or complete stupidity. We decided not to do a project that was just in the clinics. We were worried that if we just sat in the clinics and took the kids who came to the clinic, it would be like studying truancy by interviewing kids in school. So we decided, boldly and assuredly that we would go out and we would find these kids. And then we realized why everyone else stayed in the clinic, because it was completely nuts to try and do. So what we did was we took every single health facility in the rural Eastern Cape of South Africa. Government chose the Eastern Cape because it's the least functioning province in the country at the moment. So we first of all discovered that the government didn't know where any of its clinics were, so we spent 4 months finding the clinics. We then discovered that there was no filing system in any of the clinics, so we spent another 3 months sifting through giant rooms filled with hundreds and hundreds of cardboard files and finding every person who had ever started ART who was now a teenager. We then went to every single one of those files' homes to try and find the kids. It has been an instructive process. One of the things that we discovered is that about a third of people lie and gave false names and addresses when they come for ART. So we spent a long time trying to find addresses that never existed. We've now got 800 HIV positive adolescents, 812 as of this morning. And we also discovered that when we got to the homes, there was so much stigma about HIV that firstly, we couldn't mention HIV in anything that we did. And secondly, that we had to then go and interview 2 or 3 other kids in every street so that no one realized that this was an HIV-focused study. Now this tells us, I'm telling you this not to say, oh, aren't we great researchers, but to say that when we're thinking about programming, it tells us some very similar stories. If we target programs at HIV-positive adolescents, we have to think really carefully and clearly about how we can do it without stigmatizing them. But we also have to think that the easy way out of that is to put the programs in the clinic, but then you're not getting the ones who don't go. And this is a problem that would be great to get your thoughts and ideas on. So what we have at the moment is some initial findings. We haven't looked at everything by any means, and I really value your questions about what would be more useful to study now. What we're getting at the moment is rates of about 40% self-reported non-adherence to ART in the past week, and those kids who report non-adherence are much more likely to have a range of opportunistic infections. So it looks like it's a reliable measure, even on self-report. We found some clear predictors of non-adherence. We see medication side effects, we would have expected that. We're seeing that hunger doubles the rates of non-adherence. Child abuse in the home doubles the rates, as does domestic violence in the home. We see that teenagers who are depressed or have attention deficit or behavioral problems have about 1.5 times the rates of non-adherence. And we're seeing particularly high rates of attention deficit problems amongst these HIV-positive teens and high rates of educational delay amongst them. We see again cumulative effects. So with none of those 3 risk factors, about 13% of non-adherence, with hunger, side effects, and attention deficit, 44% of non-adherence. We're also seeing some adherence promoting factors, things which seem to be helping. And again, free school meals is coming up. We're seeing that good parental monitoring, high social support, and interestingly, disclosure of HIV status to the adolescent. If teenagers know their status, they're just over twice as likely to adhere. We also looked, because we wanted to test out the WHO guidelines, at what happened if you told kids before and after the age of 12. WHO recommends at the moment you tell them before 12, but they have no data to base that on. We only looked at perinatally infected kids for this, but we found that if they'd been told their status before the age of 12, it almost trebled their likelihood of adherence to ART. So it's a very strong suggestion that we should be following those WHO guidelines. But of course, it's never that easy. You don't just tell teenagers or young children, and we need to think very carefully about how to do that in a sensitive way. And I imagine it's something that Peace Corps volunteers get a lot, actually, that families and programs will request help in telling a kid about their own status. We again see cumulative effects of that, so from 31% with neither school feeding nor social support to 17% non-adherence with both of those 2 interventions. We're also working on a set of qualitative work, and we're working with a team of ethnographers who've been hanging out, something called deep hanging out, which sounds a lot more fun than what I do, with teenagers for the last 2 years to try and really understand what their lives are like. And they've been working on things like dream consultations, where teenagers act out in front of the camera what they would like a consultation with a doctor to be like. And at some point we've got to raise some money and put this into an actual video and want to use that for training trainee doctors and nurses. It's quite sad, those ones, they actually just want someone to be nice to them. They also create dream clinics where they design their own clinic and think about how they would like it. Generally, they don't do silly stuff, actually. They ask for things like heaters, they ask for slipstreams so that kids can come before and after school and not miss school but pick up their antiretrovirals. And they ask for less waiting time and heaters and food. They all ask for food. Another piece of work that we're just starting on this is to try and think up tools to help teenagers take their ART. One of the things that often comes up for them is they say that they're too embarrassed to take their ART out with them. They don't want anyone to see it. But you know, when you're a teenager, you go home after school, you don't go home. You go with your friends, you go play soccer, you go hang out. And they miss taking their medication because they're they're hanging out, they're doing stuff, or they have a boyfriend or girlfriend and they're staying overnight and they really don't want to take their ART with them. So we're working to try and see if we can design something that they could carry their ART around with them in secret, like a cell phone case that has a secret compartment, or a lipstick that you can fit one pill in the bottom of. And if anyone has ideas about this, it would be really valuable. You know, we need something to help them. I better get on, otherwise Bev's going to tell me off. Oh, but that was it.
But that's it.
We're on to the
So just a couple questions, particularly anybody who hasn't asked. Okay, or no, that wasn't a question. Okay. Yes. Okay.
I'm curious, you've given statistics on parental monitoring and teacher monitoring. What about the social service workforce and just workforce and social, you mentioned social support, I'm wondering, is the workforce included in that statistic?
Yeah, it's a good question. We are just not finding access to certainly not social workers or social auxiliary workers. We looked at home-based care, thinking that would be really high, and it was much less than 1% of the kids. It was about 0.3% of the kids were accessing it. I think what's actually happening, and you know, these are things that we put in because government and NGOs have said to us, these are big national programs. I think what might be happening is that when we go and visit a program, we kind of go to the one place where people are getting that. But if you do a national sample, you realize that it's only tiny pockets of kids who are accessing the services. We did also look at rates of abused kids. We had about 600 or 700 kids who reported severe physical, emotional, or sexual abuse. And we did an analysis to look at what proportion of them had reported it, what proportion, and what had happened afterwards. And we found reporting rates of about 50%, and rates of take-up of services or being visited by a social worker or a police officer were about 1%, and none of them had any positive outcome at the end. The only positive outcomes that came had been through community vigilante action, where the rapist usually had been attacked by a gang of people. So it's not looking great. I don't tend to present that because that sort of stuff is politically sensitive, and so I often talk to government colleagues about that. They're very aware of this and they're working on it.
Okay.
So just curious, you had mentioned non-disclosure, not disclosing to the adolescent their status. So if you tell their parents, are they the ones who would be distributing the medication or deciding to disclose or not disclose? And maybe that's part of the reason that they're not taking them.
So this whole issue of disclosure is a million times more complicated than we had anticipated. Well, and often the parents are not alive, so it's often a different caregiver. What seems to happen is that until kids are about 10, their caregiver is the one who dispenses the medication, and that programs working with the caregiver are more likely to increase the child taking their medication. Once a child hits about 11, it seems to shift onto being the child's responsibility. And that's where we're seeing these massive dips that kids are really struggling to take it. But in terms of disclosure, it's incredibly complicated because for many parents, telling the teenager or the child about the child's HIV status means disclosing their own HIV status, or disclosing the HIV status of the child's mother, for example, which has often been kept a secret and is kept a secret in the community. Parents are very worried about doing it. They're very worried about how to do it and how to say it right as well. We also found many instances where the parents thought that the teenager knew their status, but the teenager didn't know their status. And many cases where the parents thought that the teenager didn't know their status, but the teenager had worked out through Googling their medication what illness they had, or through looking through kind of life skills books in the curriculum at school and recognizing the medication name and working out through that they were positive. So it's like a complete mess. It's kind of nice binary, disclose and undisclosed. We went to hell. It's a real mess for these ones.
Okay, thank you.
Shall I move
Yes.
on?
Yes.
Okay, am I going way too over time?
No.
Okay. So the last set of things that we want to talk to you about is another set of ongoing studies. And this has been an initiative that is really aiming to develop and rigorously test child abuse prevention programs for low and middle income countries. And that's one of the activities. They're doing a budgeting activity in rural South Africa. And there's been a whole set of us working together on this in a kind of chaotic partnership throughout the world. And the program that we're starting off testing these programs in South Africa, but they're designed to be adaptable to other countries. So just to give some very brief background, in terms of child abuse prevention, the World Health Organization in 2009 did a systematic review of reviews. Essentially, they found the only thing that had evidence of working was parenting programs. They have good effect sizes in the high-income countries, but no one had really tried them in low and middle income countries. There's now been a couple of studies with younger kids, with infants and babies in low and middle income countries, and they're looking really good. A major problem that came up was that most of the best evidence-based programs, there's one called Triple P, there's one called Incredible Years that's very popular in the US, are designed by academics, funded usually on NIH money, and then sold to companies, which charge for their use. We spent about 2 years trying to persuade the two biggest, best parenting programs to give them for free in the developing world. We failed dismally. We didn't know that WHO and UNICEF were trying to do the same thing and also failing dismally. And in kind of mutual grumpiness, we got together at the end and decided to create our own versions. At the moment, there is better evidence for the child programs than for teen programs. Most of the programs really well tested are for teenagers, are for younger kids. So what was developed was something called Parenting for Lifelong Health, and USAID and PEPFAR have become increasingly involved in this. The aims are that the programs don't require professional staff, they don't need any materials apart from a photocopier. We've not worked out how to not photocopy the manuals. They're all registered under Creative Commons, so they're free for anyone to use, and they're tested in randomized trials. And we're developing 4 for the different age groups. There's a huge amount of interest in them, and they're being sort of taken up at the moment in countries ranging from Afghanistan to Papua New Guinea, and it's actually going much faster than the scientists are comfortable with. So we've got tension at the moment between nervous scientists in the middle of our randomized trials and implementing partners who are keen to roll it out, and we haven't totally resolved it. I haven't totally resolved what I think we should do. But just to give an example of some of the sessions that it would include, it's a weekly session where parents and teenagers, I've just talked about the teen one, come together and do activities together. There's very clear evidence that not just any parenting program works. There was a systematic review done which showed that they need to have some key core components in order to be effective. One of those components is collaborative learning. If you do didactic learning, it's much less effective, but if parents come up and teenagers come up with their own solutions together as a group, it seems to be much more effective. Home practice is another essential thing. If you just tell them and they go away and don't do anything, it doesn't seem to stick. It only seems to stick when they do daily home practice for at least a week at home. And there's a range of things that these programs need to have in order to work. The good news is that most of the programs are almost identical, so that creating a new one hasn't been as hard as we thought. Although what we've done is a staged development. So I'm just going to get you to very quickly practice one of the home practices that we do. Could you turn around to the person next to you and give them what we're going to call specific praise? It's not just a general praise of saying, oh, you're a nice person. It's praise of saying something quite particular about something they've done or something they're doing that has been good. So I would say, Beth, thank you so much for inviting me and for introducing me so nicely. Could you each have a go with the person next to you and then swap around?
Hi, I'm Lauren. Thanks for working at PEPFAR. Yeah, great. Thanks for asking such a question. Were you thinking it? Yes. I'm sure I was yammering. It doesn't
No. It came out fine, and you sound like a normal human on the microphone.
Oh, yeah. Thank you very much.
Were you working?
OHS.
Oh, okay. I'm in OTH.
Oh, yeah.
Right there. Yeah.
Cool. I never get to see you guys are all
shut up. You can come in anytime. I'm sure you do. It's I always imagine you're having a huge party and well, drinks are flowing and it's a dance party. It's pretty fun. Nice chatting, Lauren. Nice to meet you.
I've never had such a praise. So one of the reasons that we use praise is that many parents will use discipline as a first resort. But discipline is actually less effective on any age of children if it doesn't have a basis of trust underneath it. And one of the most effective ways of building trust is daily praise between parents and children. And surprisingly, even in a community like ours, which is probably amongst the most sort of kindly people in Peace Corps, it's not something that we actually do necessarily on a daily basis. And it is a behaviour that you need to remember to do and practice. And we find that even just introducing that basic praise at the beginning, already after that first session, you see a marked improvement in relationships between adolescents and their teenagers. You can then use that base to move on to more difficult subjects, like thinking about how you do effective non-violent discipline, but also how you can work together as parents and teenagers to plan for safety for those teenagers in the community. We're going through a long and painful process of testing. It's going to be a 6-year process of this, which we're in year number 4 at the moment. But essentially what we've been doing is testing it in smaller and then larger groups. And each time we observe, we adapt, we look at the findings, we tweak and improve, and then we test it again. Just to give some brief findings from last year, we worked with 230 participants in. This is one of our field sites. You can see our staff cars parked outside. That's a church where we ran the program. That church actually had cows that would wander in and out of the program and occasionally knock over the camera that we were trying to use to film it. But one of the things that we're trying to do is to make this a real trial. So the implementation, all of the programming was done by local NGOs of people living in this area. And it's a terrifying thing for a research scientist because you've lost all control. And you just have to hope to hell it works out. But luckily it did. And what we see is effect sizes of about 75% reduction in child abuse, physical, emotional, sexual abuse and neglect. We see reductions in adolescent delinquent behaviour, both aggressive and problem behaviour. We saw reductions in carer and teen depression, parenting stress, caregiver drinking, poor supervision and inconsistent discipline. We saw increases in involved and positive parenting and social support. We saw that teens got more social support from their caregivers, but not from their friends. That didn't improve. And we also saw no change on teen alcohol and drug use. So overall, it was looking really positive. It is only a pre-post test. And so the next step was to move on to a large-scale randomized control trial. However, in the meantime, some unexpected things happened. One was that government got really involved. They came down to see the program, decided they loved it, they wanted their own teenagers to enter this program. That would have been lovely, except they then decided to scale it up nationally now, before we'd done the randomized control trials. So we've been having some debates about that. We also had an unexpected diffusion effect, which was that families who'd been in the program started telling other families. They then started setting up their own parenting groups to train other families. And we also discovered that local pastors had gotten hold of the manual and were preaching weekly sermons from the manual. And that local school principals were delivering assemblies from the manual. This was wonderful. This warms the hearts of our NGO colleagues and chills the hearts of a researcher, because it meant that I had to go from a small-scale randomized control trial with 200 people in 3 villages to 40 villages with 1,000 participants. So we're just in the middle of this painful and difficult process right now, and in about a year's time I should be able to come back and tell you what the results are. Just to say as well that PEPFAR USAID, as part of the special initiative, are also testing out one of these parenting for lifelong health programs. They're trying something called the book sharing program, which is aimed at toddlers, and trying that in Lesotho. And some of you will recognize an intrepid intrepid person on a hillside in the freezing cold in Lesotho a few months ago. So I just want to end before we go into questions by thanking our very tolerant funders, and to end with some key evidence take-home messages. The first one is that family HIV clearly puts children at severe risk. The second is that cash and psychosocial care protection does seem to be able to reduce that risk, and particularly when we combine programs for the most vulnerable. We do have initial evidence that parental support programs can reduce abuse, and I think what's most encouraging for us is that this is evidence of real life stuff that's happening on the ground in Sub-Saharan Africa. It's not a set of genius sort of researchers coming in and running a perfect program on the small scale that then programmers say, you know, how the hell are we supposed to replicate this? This is stuff in the real world, and it seems to say we really can do something. So thank you for listening so patiently and praising so brilliantly.
Thank you so much, Lucie. It's just been really marvelous to think about how we might be able to apply this. We've got people not only from Peace Corps, but also from other NGOs and US government and a variety of people here, and we just really appreciate your generosity in sharing the latest research with us. And now we do have time for more questions, so feel free. Yes, okay, question back there.
Thank you for your talk. One of the things that
Can you speak up?
one of the things
Super.
is better. One of the things that I was thinking through when you were talking was in terms of decreasing the number of youth who are aware of their status as well as medication. It seemed like there was a real need to ingrain prevention and maintenance, which is overall youth development frameworks, right? Because there was a point where you couldn't say this person had HIV. They didn't know. There was stigma. There was a lot of things, right? And understanding that in the countries of Sub-Saharan Africa, it might not be a robust youth development system. To what extent is that true or is that not true? And are there organizations who are trying to embed that in this overall youth development framework, and how effective can that possibly be? And my other question is—
Okay, stop that. Let me answer that one.
Why don't you kind of summarize the question?
Okay, so this was a question about youth development programming. First of all, is it existing in Sub-Saharan Africa to an extent that's helpful? And secondly, is it integrated with these kinds of HIV questions? In my experience, there's very little youth development programming. That many agencies are set up to stop at 17, partly because that's when we cut off for children. And I think the Dreams Initiative has recognised the danger of that, because what happens is we start to see particularly HIV infection risks skyrocketing at 18 to 24. The youth development programming that I've seen has generally not focused on those things either. What it's often focused more on has been employment and apprenticeships and things like that. But it'd be great to hear what other people think of this as well, because my experience is only in a few countries. I think it's huge potential, and to provide programming and support for those ending teenagers and going into early adulthood it's just such a gap. Really highlighted them. You had another question though.
My other question was, would you classify your research, I guess, as action research? And if it's not, how would that affect
Okay, so is everyone familiar with action research? I'm not 100% sure I know what it is. So I think what I would say is that we do action research on the slide. So what we we have to. It's pretty valuable for HIV advocacy with children that our research is seen to be extremely scientific and huge level longitudinal survey research. Of course, what we end up doing whenever we see a kid who needs it is that we go and help them. And many researchers feel that that's not a good idea because you're interfering with your longitudinal study. we're a bunch of social workers and we feel differently. It's a great question and a difficult one. So the answer is it depends who's asking.
Okay, other questions?
I was a Peace Corps volunteer in Kenya, and I was, my name is Carl Schwarm, and I'm a Peace Corps volunteer in Kenya.
Put it a little closer.
Sure, and one of the things which was really interesting about the communities was they were layered approaches to school feeding programs, and you had safe schools programs. So when you were looking at these different communities, within, I assume they also had all these different layers of support as well. And how did you tease that apart, and which ones have been more successful? And kind of the second question. Safe schools programs are something that Peace Corps does, and they oftentimes include a parenting component to them. So just looking at, is that a good starting place? Is it a good, not a one-stop shop, but is it a good foundation? Have you seen that?
Look, we were limited by what we had, by what we'd asked, and of course there are things that we now really wish we'd asked and we didn't. And we were limited by what was actually being accessed in these places. I would say that the evidence here suggests that parenting programs and safe school programs that improve the school environment, are going to be positive. But I would really prompt you to test that out. Because it may be that we need to shift the different combinations to hit the best outcome. And of course, this evidence is mainly from South Africa, not from Kenya, and things may be a bit different. Although the evidence so far suggests that we're seeing the same effects. There was a study done in Malawi as well, where they compared conditional and unconditional cash transfers and found the same effects of both. So it's building evidence that these are transferable. But when it comes to specific programs, it would be really great to have some testing of those. And often we don't think to test of outcomes beyond the ones we think of automatically. So when we test, if we do a safe schools program, we might test whether school attendance is improving. We might test whether kids feel safer at school and happier at school. We might test their nutritional status, but we may not test their HIV risk outcomes because we don't necessarily think about the next risk on, in a way, the follow-on risk. And I would really urge you to try it. We're happy to share everything we've got as well, if that makes it easier, because research is tough as well to do.
And you mentioned too that some parenting programs work and some don't, depending on the actual effective elements that are part of that.
It seems to be, yeah. I mean, but what's difficult is that in the West there are multi-million dollar, some people think $1 billion sort of business, and so what we're doing is a bit of a sort of renegade approach to that. But it seems that countries are incredibly interested in them, and so it's something that if you're working with governments, they're incredibly excited to get going on parenting programs, and so it's a great opportunity actually.
Hi, thank you. I want to know whether, based on your research, you're able to compare, looking at the outcome of the goal of well-being of youth and adolescents, compare the effectiveness of economic interventions, cash transfers, when they're delivered to the family, caregivers, or whether it's delivered directly to themselves.
Great question. Our data just doesn't have it. In South Africa, even when you deliver something to one person in the family, it gets shared out amongst the whole household. And the evidence from the whole of Sub-Saharan Africa suggests that as well. So it may be a bit of a false question, actually. They did do it in Malawi, I think, and they found that it made a difference to have a small amount of the money go directly to the teenager, but I think it was something like $1 a month or so. It was a tiny amount. Have a look, it's by a paper by Sarah Bard, B-A-I-R-D, and they looked. That's the only place I know that's compared that. We're early days with this stuff. We don't know all the answers yet, unfortunately.
Two things. One is thank you so much for this. And because you have so much information here, and we only have an hour and a half, is there a way that we can get access to more information about these programs and the research results? How would you direct us to get more? There's so much there. So, and the second question is that it's so we're very, at least I work for the US government, we're very verticalized, and so good that you actually look at doing HIV focused research, but you include, for example, early pregnancy in your results. And that's really helpful to look at the broad ramifications in domestic violence and gender-based violence, as well as unintended pregnancy, as well as HIV and sex-based behaviors, which is really good. There's also early marriage. There's a big global focus now. And anecdotally, I hear that sometimes that maybe kids who are in HIV-affected households are more prone to early marriage. And I know, it was transactional sex, early transactional sex versus early marriage, but the fact is that there's a big global focus on early marriage. And I was wondering if your research provided information that would be informative to that too. But thank you again for this. It's really important to have this kind of strong research to help us as we move forward.
Linda was one of the people that back in 2007 was knocking on her door, her and Ben's doors, asking what we should include in these questionnaires. So it's lovely to have you here. In terms of more information, we have a website with almost all of the papers up on it. A lot of the stuff that you saw today is not yet published. We're still in process, and we're happy to share the PowerPoint.
And just to jump on that, would the best website to find particularly your research and the papers that are coming out based on this on young carers?
Yeah, well, we've got my official Oxford one where we're not allowed to upload anything because it's all copyright protected, but we've got another one called www.youngcarers.org.za, which should have all of the publications up there. And I'll check. I've got a student working on it right now. The question about early marriage, though. In South Africa, so few people get married at all, at any age in these communities, that we just don't see it there. However, this is an example of where we shouldn't be just relying on research from South Africa for the rest of the region. It would be absolutely crucial to do some research in countries like Swaziland and Lesotho in Mozambique, where we are seeing severe rates of early marriage. So we got no one, but no one seems to be married generally, apart from the much older generations.
Thanks. So disclosure. What are you thinking about doing about it? What interventions do you see? The only one I've seen that I'm familiar with is the Baylor step to official disclosure model. How do you see that moving? How do you see us pushing that at the local level?
This is Melissa, who just got her doctorate. So Dr. Sharon, thank you for the question. We have no idea. We only finished these analyses about a month and a half ago. There's someone at the Africa Centre called Townsend Roshak who's developed a disclosure program for mothers of under 7-year-olds. And she's done a small randomized trial on it, and it's looking really great. But we just don't know of any evidence-based disclosure programs beyond that. And I think what we're going to need to think of as we develop and test these is that they need to be quite simple, because the people doing the disclosing are not going to be able to follow very complex processes. And I think this is something, again, this is the thing about HIV. As soon as we've solved one problem, as soon as we've got kids on ART, there's another whole set of problems that come up that we just haven't got answers to yet. It's not that people should have done them but haven't, but it's a new thing. We've got these new generations of teenagers, and we need to know how to care for them. And I do think this is as well where an organisation like Pew School, with you've got influence, you've got people on the ground, you've got kind of smart, young, innovative people, and you've got some cash, have the opportunity to develop and test stuff like this. We need it, because at the moment no one knows what to do. There's some lovely examples from our quals where doctors would say to kids, HIV is like a Tutsi, like a gangster, and you're the policeman. And if you take your ARVs every day, you shoot the gangster every day, and you get him into prison, and you keep him locked up in prison. And they're trying all sorts of stuff, but it'd be great to find out what really works. I'm not sure if shooting gangsters is the best analogy.
Lucie, hi. Hi everyone, I'm Erin Wallace. I used to be involved in civil health and HIV, and now I'm in in the OPAS. And I just wanted to make a public thank you to Lucie for all of her contributions she's made to our training packages that we put together, Bev and I, in Office of Global Health and HIV. We've used your research. We're hoping that the research informs the programming. We've tried to make those connections within our training packages. So if you're on the internet and you want to look for them, they are there. We also developed a manual to support families caring for children affected by HIV. Within that, we do have a draft of the parenting, one of the parenting sessions. So we are really, really grateful. Thank you for all of your work and contribution to our work at PEPFAR. We do have a question for you about developmental impacts of HIV on kids. So I know a few of the slides mentioned behavioral attention deficit, behavioral development, cognitive development. What's going on right now in the research world around those areas? It's something that we kind of love, and maybe we'll get some more attention in years to come, but just wanted to hear from you on what you know is going on with that.
Well, Lorraine Scher's research is showing up some of the best stuff on this. This is about what's happening cognitively to children who are born of HIV-affected parents. And it's been really difficult for us to know, because until about 5 years ago in Sub-Saharan Africa, they were all dying before the age of 5, so we couldn't look at much, and they were so sick we couldn't do much with them. What these systematic reviews are showing now is that there's very clear evidence that children who are born HIV positive have much higher rates of cognitive and developmental delays, also motor delay in terms of development. We haven't got any studies that follow them up long enough through their lives to know much about what's going on above about age 5. What's also interesting though is a group which no one had thought about before, but which Lorraine Scher calls HIV-exposed children, who are born to a positive mother, but who are born negative through either through luck or through PMTCT. And they are also showing cognitive and developmental delays, slightly less than the positive kids, but clear evidence of that in reviews. And that suggests that's a group we hadn't really, we kind of thought once they were born negative it was okay. We don't know how much of it is nature and how much of it's biological and how much of it is the caregiving environment. What we're seeing in our study of the positive teens is extremely high rates of developmental delay in teenage years. We're seeing very high rates of school dropout. They're dropping out of school because they fail year after year, and they're ending up age 15 in a class full of 9-year-olds, and that's just a miserable experience for a 15-year-old, and so they drop out of school. Schools are not ready for this group, and I went a couple of weeks ago to talk to the Department of Basic Education in South Africa about what are we going to do about this. This is really coming. And I think this is something where, again, there's opportunities for Peace Corps, because these kids, there is evidence with cognitive delay that good intensive tuition can actually really help kids keep up, and yet there's nothing in place for this cohort. The one other thing that's really worrying me is we're seeing, and look, this is anecdotal now, I haven't analysed it, we're seeing very high rates of rape amongst the HIV positive teens in our sample. And it's just a gut feeling, it might be wrong, but I don't know whether it's connected to the cognitive delay. You do see in other samples that rapists will choose children who are less likely to disclose, who may not be believed if they do disclose. And it could be that they're at that particular risk as well, these kids. But we'll take us another year to analyse that data.
Other questions? Okay, yeah.
I too wanted to thank Bev for bringing you, and thank you so much. I don't think this is not on. I think you can all hear me? Can everybody hear me? Okay. And I had two questions. One, an idea that you had asked us to mention if we thought of something, but I wanted to get your thoughts on it. And second, having to do with the Peace Corps. The first question has to do with how you address the ART adherence. And you were talking primarily, it seemed like, about school groups. You know, they're coming out of school and not adhering to it because of the things going on after school. Okay, so maybe that's not appropriate. But for those groups in school, the thought was, would there be some way that the school could be involved where there's maybe backpacks that are uniform? Everybody goes down at one point during the day to the nurse, or if whoever they have, and if they are HIV positive and getting drugs, they would put them in the backpack. If not, they ask them a question or do something else. So there's no stigma maybe attached. And I didn't know that. And would that also then enable you to test whether while in school, adherence rates are high, and then while school's out, they're lower, so that actually could work? And could it test whether once they're above age for school, which might be this like rapid increase you're saying you're seeing in the 17, 18-year age to 25, which is still youth, but after school, unless they're going to higher education, which is low rates, I'm sure, that when they're not adhering anymore too, because they lack those structures that they have.
It's a really interesting question. This is like a conundrum for us. Because I had exactly the same thoughts as you. You know, could schools do something about this? And I went to speak to the education department, and their response was interesting. They said, we're terrified to do this in schools because parents don't want anyone in the school to know, because the school is a hub of gossip in a community. And as soon as one teacher or nurse in the school knows the HIV status of that child, they know the status of the family, and then everyone in the community knows. And that's why they're terrified. They even said they were scared to do breakfast feeding schemes for the positive kids. They could do them, but they were scared to do them because they were worried about the stigma. Now that may be better in some countries. You know, it's said that there's lower stigma in Uganda than there is in South Africa. It may be doable some places, but in South Africa they just said, we're terrified to even try. And they're even more terrified because they tried school testing in South Africa a couple of years ago, and a whole bunch of kids committed suicide, and so and it was badly done, and there was lots of gossip, and so they're really scared of it. But it's a really interesting idea because schools are our opportunity in some ways to we've kind of got them there, we've got the kids there, we can do stuff with them while they're there. But the HIV messes with it, and we're going to have to think really creatively.
Maybe that's where the Peace Corps could come in.
Potentially, yes. Potentially a relationship which can have confidentiality and support, and which looks cool for a teenager. And I mean, we've got to remember that when you're a teenager, remember when you were 14, being cool was your single greatest goal in life. That was all I wanted. Well, maybe I wanted Johnny from down the road to like me, but that was all mixed up with being cool. You know, and it's not different for these kids. We did an activity with them a few weeks ago where we asked them, how would they say things? What language do they use? And what they produced for us was a whole range of text speak that was incomprehensible to us. My favorite one was JC, which I always assumed meant Jesus Christ, but actually meant just chill. But if we're going to get these programs right, we've got to get at their level. Most programming, most health and social services programming in Sub-Saharan Africa is delivered by adult, and this does matter, adult, sometimes very moralizing, particularly Christian moralizing approaches. And this can really be difficult, particularly for something like HIV positive teens when they want to get family planning advice. Major problem for them. They get told they shouldn't be having sex, they get told that they're morally wrong, that they're going to go to hell. And this is where young people actually do have an opportunity to engage in a way that the adult workforces can't. And I think we've got to start thinking creatively about this. Right now, if you look at this, it suggests that free school meals, that improving parenting and disclosure are going to help. But there's a whole load more things that we should be looking at and testing.
And the second question is more of a Peace Corps one, and it may be that somebody from Peace Corps or you could, but is there any way we can have a speaker, such as yourself, working at an IST at the post level to encourage, really good in-service training, in-service preparation for volunteers?
Yes, and we are trying to work on how do we really integrate evidence-based programming. And we're going to be into our training of Peace Corps volunteers. We're actually going to be meeting with her this afternoon, specifically talking about how to implement that more effectively.
Although interestingly, Peace Corps is doing more evidence-based training with their volunteers than any other volunteer organisation that any of us know. So yeah.
Such powerful information, and these kinds of questions could come up directly from volunteers instead of second and third hand by the time they get there and all pushed up.
Yeah, and then that ties into how do we at Peace Corps promote evidence-based programs through PC Live, through various ways.
Yes.
Those are
like,
issues
once
that
it's
we're
taped,
talking
could
about.
we share it?
Yeah,
Those kinds
yeah.
of things, yeah.
And this did go out to, this, you may have noticed, this was on Google Hangout.
Oh, great. I did not notice. But thank you.
That was that little thing that she asked me to hide. Anyway, so we're hoping to make this available to more folks, and it's part of our how do we share knowledge better. Is there one last burning question? Otherwise, I think, okay.
I would ask one.
You would ask for? Okay.
Yes, another
Okay.
one. Thank you. So you had spoke about psychosocial issues, especially with males, and that it was very difficult to make any changes. I'm just curious, why so high in the males? Is it the pressure that they have to work or provide for a family?
Good question. Well, this is probably what we were thinking about. With males, actually, it sort of seems to be the opposite. Well, so we certainly do see high rates of HIV risk behaviour, higher rates of HIV risk behaviour amongst boys than girls. That might be because you always get higher rates of sexual behaviour reported amongst boys than girls. Girls tend to underreport and boys tend to slightly overreport. They do those studies where it's consistent internationally in every bar in the US probably. But what's interesting about boys actually is the massive importance for them of parental support and teacher support. That without that, we don't seem to have an impact. But that for boys, it seems really important that they have this kind of additional social structure that improves their behaviour. And we don't quite understand the dynamics of that yet. We don't know what's going on in those conversations, what's going on in their heads. But it does seem to make a real difference. That we can't just provide economic support and expect that boys' HIV risk behaviour will reduce. We've got to provide psychosocial support as well. What's difficult is with peer support. Now, if you just look at whether teenagers have good peer support, then they tend, it doesn't really work with your friends, because your friends can be very supportive but in a bad way. So kids in gangs have amongst the highest peer support of any kids because they're in a very tight-knit network and their friends are backing them for everything. So it seems that there's real potential with peer support, but that we need to make sure that the peer support is in the right direction rather than in the wrong direction. And I think, again, that's where Peace Corps might have potential. I think the Peace Corps volunteers are often looked up to as aspirational figures within a community and do really have potential to be that, to provide that kind of emotional support that teenage boys seem to really need, but maybe can't be seen to ask for. And when you're 15 and you're a teenage boy, things are pretty tough anyway.
Thank you so much, Lucie. This has been excellent, and I know that for many, not just within Peace Corps, but in many of our extended networks of the NGO community and the government community will benefit from this, and we really appreciate it. I'm just going to tell you that then the next thing that Lucie has to do here at Peace Corps at noon is going to be meeting with our directors of programming and training to talk about particularly an initiative on Let Girls Learn and how we can influence schools and girls going to school. And then in the afternoon, I mentioned that she's going to be meeting with a bunch of technical advisors to talk about how we can really apply this kind of research into our training and support of volunteers.
So we just really appreciate your generosity and sharing all this with us. It's been an absolute delight having you here. Thank you once again.